I'm going to do clinical pearls. This is going to be a case-based talk to really go over some things that actually weren't covered in a lot of detail in the other talks, really very clinically oriented and things that span across cancers. We'll then do a Q&A session, and then the last will all be a question and answer style ones with a board review. All right, so now we're going to go into oncology pearls, no disclosures. So like I said, I really wanted to review some general oncology topics really in a case-based format and really cover topics that are going to span multiple cancers. And like I said, this will all be case-based, not necessarily breast cancer cases, but all types of cases. So let's start with the first case. 60-year-old man with 80-pack year smoking history. He complains of a 1-week history of facial swelling and cough. On physical examination, he has distended neck veins, prominent chest wall venous distension, and facial edema. His chest CT shows bulky right hilar and mediastinal adenopathy. And so the choices are A, would you proceed with a mediastinoscopy or bronchoscopy to obtain tissue? B, initiate heparin and radiation with a plan to a biopsy when swelling improves. C, initiate steroids and heparin with a plan for a biopsy when swelling improves. D, initiate heparin and emergent stent placement and then biopsy once swelling improves. Or E, explain to the patient that this is metastatic cancer and he should consider hospice. And I'll give everyone a chance to answer. It seems that the most popular ones are, so the first one is the most popular one at about, keeps on changing, about a third, but a reasonable number of people chose to initiate heparin, initiate steroids, or initiate heparin and emergent stent placement. And I'll explain now why you actually do have time to proceed with a mediastinoscopy or bronchoscopy. So to talk about the signs and symptoms and optimal treatment for SVC syndrome. And so really greater than 50% of these are due to malignancy. It's due to the tumor either compressing the superior vena cava or less commonly directly invading the superior vena cava. Lung cancer, both non-small cell lung cancer and small cell are the most common. Lymphoma does it as well. Breast cancer, I've had breast cancer patients present with SVC syndrome as well. So anything that presents in the mediastinum. Now, because of the increasing use of catheters, thrombosis actually is a reason for SVC syndrome. Now about almost 20 to 40% are actually due to catheters in the chest. So what do you see? You see facial edema and plethora, jugular venous distension, and venous distension of the superficial veins on the chest, which really can be quite impressive sometimes. The symptoms are shortness of breath, cough, and hoarseness. But the good news is that as you can see here, and this is the grading of SVC syndrome, really only less than 1% are fatal. So even though obviously, yes, it's scary when you see someone who has like a swollen face and has all these swollen veins, you have to think it happened pretty slowly and gradually to get to that point. SVC syndrome, it's not like the tumor exploded overnight and grew. So it actually is very, very rarely fatal. About 5% actually are life-threatening, but as you can see, the majority of people who have SVC syndrome, 50% moderate, 25% mild, and 10% are actually asymptomatic. And so you want to make sure that there's contrast. You have to have contrast in the chest CT because you have to be able to tell the difference between the lymph nodes and the vessels. If you don't give IV contrast, you're not going to be able to tell the difference between the vessels and the nodes. If, however, you're like, I really think this is catheter related, this is someone whose cancer I know is under good control, then you can actually just do an ultrasound. But you really need, for the gentleman I present in the case, you actually don't know what kind of cancer he had. You just knew he had a smoking history. And it looked like cancer, so the treatment really depends on the tissue histology. So chemo-insensitive cases, non-small cell lung cancer, you sometimes will do upfront radiation, less likely stent placement, upfront radiation, whereas chemo-sensitive tumors, and I'm not saying that non-small cell lung cancer doesn't respond. It obviously does. Dr. Jackman showed us plenty of data about that. but it responds a little bit more slowly. Versus small cell cancer and lymphoma, it's really impressive. I mean, you give people treatment, and like 2-3 days, the thing can be melting away. So those people get upfront chemotherapy. And so that's why you really need tissue, because the treatment algorithms are completely different depending upon the histology of the underlying cancer. There are a few indications for urgent stent placement, and I did not describe this in the case. So obviously life-threatening symptoms, airways obstructed, severe laryngeal edema, you're not going to tell that person to wait for a tissue diagnosis. I wrote here diagnosis not established, and I guess what I was referring to there is we don't know whether it's cancer or not. Obviously, the other person we're suspicious it's cancer, and then refractory or relapse disease. So someone you'd already treated, you're unsuccessful at treating, they're growing through everything, then that would be an indication for a stent placement. But as I said, despite how scary it looks, it usually is something that happens fairly gradually, and so it's rarely fatal. And so now we're going to continue with the same man. He turned out to have lung cancer. And so he's been treated with pembrolizumab for 3 months. He presents with 2 days of a dry, non-productive cough. He denies that he fevers, chills, or dyspnea. His viral panel is negative. He actually looks very well. His lungs are clear, but you notice that even though his room air saturation is 96% at rest, once you have him ambulate, it actually desaturates to 90%. So then the question is, what would you do next? Would you immediately set him up for bronchoscopy, start empiric broad-spectrum antibiotics, start inhaled steroids in a bronchodilator, do a CT scan, or start prednisone at 1 milligram per kilogram with a slow taper? And people are favoring CT scan, which, oh yeah, by quite a bit. Yeah, once I give you a little bit longer to answer, yeah, by quite a bit, CT scan. So even though, yes, this is likely immunotoxicity, you have to start with a CT scan first. And this is actually what we're going to talk about, immunotoxicities. So immunotherapies, there are a lot of different drugs, and basically almost every single cancer can be treated with some type of immunotherapy. Some of them are what are called PD-1 inhibitors. Some of them are PD-L1 inhibitors. Some of them are CTLA-4 inhibitors, and I have different ones listed. But the side effect range, which I'm going to talk about, is really quite a wide range. What's important to remember is, unlike chemotherapy, it is not necessarily dose dependent. It's not as if, oh, you have to wait until you accumulate a certain amount of dose. That's not true. That does vary a little bit with the type of agent, but the other thing is that timing is highly variable. So I have some people who finished immunotherapy, and then 3 months after finishing immunotherapy, they then develop toxicity. And it's because the drugs really can stay in the system for quite a long period of time. And it can be fatal. So it is very important to recognize. So the first two I'm going to highlight are the two that are most likely to be fatal. So first, gastrointestinal. It can cause colitis, and this colitis can be severe enough that people can die from it. It commonly presents as diarrhea. It really isn't nausea and vomiting. It's really diarrhea and sometimes abdominal pain. If they have a lot of nausea and vomiting, you do have to wonder, is it something else? Hepatitis also, people can die of hepatic failure. And it's mainly AST and ALT abnormalities, not as much bilirubin abnormalities. Pancreatitis is pretty rare. And then the other one that people die of is pneumonitis. It occurs in about 10% of people. It generally presents as ground glass opacities. So it's generally not going to be like a lobar pneumonia or anything like that. It's definitely not going to be like metastases. No, it's generally ground glass opacity. So it's often tricky. Is this infection? Is this a viral infection or PJP? Or is this pneumonitis? I actually have someone who was just admitted to hospital yesterday who the house staff emailed me. She's got ground glass opacities. Do I think this is pneumonitis, or do I think this is a viral syndrome? And I said, well, we have to treat her for both, because I don't know yet, but it really can rapidly worsen. And these are the two that are most likely to cause death, so really are important to recognize. The one that is more of a long-standing problem is the endocrinopathies. These actually can be lifelong, and it's tricky because, for instance, in a breast cancer and some other cancers like colorectal cancer, you're treating people with curative intent, and you then give them hypothyroidism or hyperthyroidism that they have to take medication for the rest of their life. You're giving them primary adrenal insufficiency. I have a patient who, has had excellent results from her triple negative breast cancer, but now she has permanent adrenal insufficiency and is going to be on hydrocortisone for the rest of her life. And so these, although they're unlikely to be life-threatening, they actually can be major quality of life issues. Arthritis, myositis also can be significant quality of life issues. Dermatologic, some very unusual rashes. And then there are a lot of other rare things: renal, CNS, hematologic, cardiac, eye, but these are all pretty rare. But immunotherapy can do anything and everything under the sun. And so the management really it's extremely steroid responsive. So if you're concerned about immunotherapy, you have to start fairly high dose prednisone at 1 milligram per kilogram. It's obviously tricky because the pneumonitis ones I was talking about, sometimes you're worried, is it infection or is it pneumonitis? Do I want to give steroids if there's an infection? So it can be tricky, and it needs to be a slow taper. That's the other thing that's important. It can't be just a 2-week taper. It needs to be at least a month. And sometimes what happens is you try to taper, and then as soon as you get a little bit of a taper, it's all of a sudden the LFTs go back up again, or the colitis starts up again, and then you need to go back up again on steroids. The good news is that it doesn't mean that you can never get immunotherapy. It depends upon what the toxicity was and how severe it was, but you can sometimes restart the immunotherapy. And as you can imagine, when we're treating with curative intent, we can push a little bit harder than when you're treating with palliative intent. But it really can worsen rapidly. So you really need to ensure close follow-up. It's not like I'll call you next week. I'll call you in 2 days. I'll talk to you tomorrow, because the natural history can really get worse dramatically, quickly. And it's really key to involve your specialists early, gastroenterologists, the pulmonologists, because of the fact that people can worsen so rapidly. So case number 2, this is a 64-year-old male with metastatic prostate cancer of the bone with metastases to the ribs, pelvis, and multiple vertebrae. He's currently on docetaxel chemotherapy. He calls you complaining of 1 to 2 weeks of increasing mid-back pain. He has no weakness, radicular pain, bowel or bladder difficulties. His neurologic exam is normal. And would you order a bone scan and CT scan to look for disease progression, administer zoledronate 4 milligrams IV, order an MRI of the spine, urgent radiation oncology consult for radiation to the spine, or start prednisone 20 milligrams? And this one was really easy for everyone because the majority of people said, oh, wow, I should have, actually, I guess it wasn't as easy. So half and half said order a bone scan and CT scan to look for disease progression, and the other half said an MRI of the spine. The reason the correct answer is MRI of the spine is we're specifically looking for cord compression, and the bone scan and CT scan are going to be inferior to the MRI for cord compression. So let's talk about cord compression, because anyone who spends time in the emergency department or as a hospitalist will come across cord compression. So the key is you have to initiate treatment early to prevent neurologic defects. If they're already like, I can't walk, I can't stand, you're in a lot of trouble by then. So you really, because some of these can be irreversible. As you can imagine, the cord is delicate. It usually is from epidural compression. It's not usually because there's tumor sitting in the cord. It's usually because there's tumor in the bone marrow, in the bone, and it's compressing. And I'll show you a photo in a second. The most common tumors that does this: lung, breast, prostate, myeloma, lymphoma, and renal cell. The thoracic spine is actually the most common area for cord compression because it's where the spine is narrowest. It's also most vascular. So I can tell you, if you have someone with cancer and they complain of mid-back pain, you should definitely be worried. If they complain about low back pain, sometimes you're worried, but sometimes it's just low back pain. But mid back pain, as you know, degenerative changes are not common in the mid back. So I always am worried if someone says, oh, I have pain in my scapula or pain that's high up. And as I said, intramedullary metastases are less common. So this is what it looks like. As you can see, it's a metastatic tumor that is growing, and then you can see the cord is being compressed by the tumor in the bone, and you're seeing the same thing on the MRI. Again, it's tumor in the bone that's compressing against the spine. So obviously the symptom is back pain, and obviously someone needs to have vertebral metastases. So if they have a cancer and it only has liver mets and they don't have known bone mets, you're going to be worried less. But if someone has bone metastases, you definitely want to worry. Radicular pain is more of a concern. Numbness and paresthesias, weakness, and then bowel and bladder symptoms occur late. So you do not want to wait until the person is incontinent because by then that's really one of the last symptoms. And it's really important to remember that people can have cord compression with an entirely normal neurologic exam. And the key is early diagnosis, with MRI being the imaging of choice because you want to be able to see the cord and the metastases separately. The CT scan, you can't see it as well. So you definitely want to start corticosteroids. It's short-term benefit, but they will immediately notice usually an improvement in any symptoms that they have. And it's fairly high dose, 10 milligrams IV load, or I forgot to write down dexamethasone. So it's dexamethasone, 10 milligram IV load, then 4 milligrams POQ 6 hours in the beginning. And for most cancers, radiation is the first line treatment. Upfront surgery is mainly for people with an unknown diagnosis. So you didn't know they had cancer, and this is a new diagnosis. Progression during or after radiation, you cannot radiate the cord twice. There are some other areas that you can radiate more than once, but the spinal cord, generally, you will not radiate more than once. Any instability in the spine. Interestingly, there was one randomized trial that showed improved function with immediate surgery for less radiosensitive tumors. But the trouble with that study is they had everyone go into the operating room within 24 hours of presentation. Even at a major tertiary care center like ours, that's extraordinarily hard to do. So now we're going to move to a completely different case. Case number 3, different topic. 62-year-old woman presents to the ED with a temperature of 101, malaise, and cough 15 days after receiving chemotherapy for refractory lymphoma. Her physical exam is unrevealing for a source. The white blood cell count is 640 with 45% polys. A chest x-ray is negative and cultures are obtained. Can you start? Thank you. So the choices are admit patient and start cefepime, admit patient, start cefepime and G-CSF, admit patient and observe, discharge the patient home on oral quinolone and G-CSF, discharge the patient home on oral quinolone. Yep, and as I suspected, yes, that's usually what happens, is the two most popular answers are A and B, but the answer is not to give G-CSF. It's just to actually give cefepime, and I'll show why. And so just the definition, fever and neutropenia, oral temperature greater than 101 for more than an hour. Absolute neutrophil count, as this person had, less than 500 because it was 640 with 45% polys. And the reason why is that there were multiple older studies that showed that the risk for occult infection and mortality increases as the ANC falls below 1,000. The greatest risk, however, was with an ANC less than 500. Interestingly, the mortality rate for solid tumors, so you have the same ANC, the mortality rate for solid tumors is less than that for hematologic malignancies. Growth factor, it does shorten duration of neutropenia and hospitalization by a little. By what I mean by a little is like maybe a day. There's no impact on mortality. And so because it's not a huge difference, there's actually thought to be no significant benefit to empiric use of GCSF in uncomplicated fever and neutropenia. This is different than a transplant patient or something else, but just an outpatient person who comes in with an uncomplicated fever and neutropenia. So risk factors for fever and neutropenia: rapid decline in ANC, prolonged duration of neutropenia, leukemic induction, uncontrolled cancers, and then hematological cancers. These are the typical infectious sources. And often, however, in less than 30% of cases are sources identified. And the other thing is they didn't catch something from someone else. It's really endogenous flora in 80% of the cases when a source is identified. Likely organisms, usually gram-positives, but gram-negative rods are more likely to cause death. So that's why you have to have broad spectrum coverage. There's just routine evaluation. You don't necessarily need to do a CT scan. And then empiric treatment is broad spectrum antibiotics, generally a third generation cephalosporin. And these are all the alternatives if someone is allergic to cephalosporins. But to remember that there's less than 1% cross-reactivity between the first and the third generation cephalosporins if someone does report an allergy. And so should you be using vancomycin? So this is something we really would discourage. Empiric initial use does not improve morbidity and mortality. Instead, it encourages development of vancomycin-resistant enterococcus. So really only give empiric vancomycin if there's a high suspicion of a line skin infection, mucositis, has a history of MRSA, or severe penicillin allergy. And then, are there people you could treat as outpatients for fever and neutropenia? We actually don't do this a lot in the United States, but it actually would be reasonable to consider for people with solid tumors, clinically stable, and no major comorbidities with a short duration, anticipated duration of neutropenia. So case number 4, a different case. 68-year-old woman with metastatic lung cancer who's brought to the ED with her confusion. Her serum creatinine is 17. Serum calcium is 17, and her creatinine is 1.5. 4 liters of normal saline and IV furosemide are administered. What is the next most appropriate therapeutic intervention? Is it another 2 liters of normal saline and furosemide? Is it denosumab 120 milligrams IV? Is it zolendronate 4 milligrams IV? Or is it chemotherapy for lung cancer? Yes, and this one most people got right, which is zolendronate 4 milligrams IV. Denosumab is given sub-Q, and chemotherapy for lung cancer is not going to work quite fast enough to bring the calcium down. And so this really can occur in both solid and hematologic malignancies, most commonly breast, lung, and myeloma. The incidence, however, really has been decreasing significantly among metastatic patients because we now use bisphosphonates routinely for prevention of basically fractures and pain. However, we still see hypercalcemia either in some of our patients who are unfortunately non-compliant with treatment or other people who have refractory disease not responding to treatment. So we obviously do need to treat hypercalcemia because it's important for palliation, but we really need effective anti-cancer therapy. And that is the only way in the long run you're gonna be able to keep the calcium down. And the causes of hypercalcemia, the most common is the humoral hypercalcemia of malignancy, the tumor secreting PTH-RP. The other 3 are much less common, with ectopic PTH really be extremely rare. That's just like isolated case reports. But regardless of the etiology, they're all treated the same: IV normal saline volume repletion, and then either bisphosphonates or denosumab. Calcitonin does work very quickly, but it's much less potent and doesn't last for very long. Dialysis is not used that much for our cancer patients for hypercalcemia, but it would be if someone was in renal failure. So how do you choose between bisphosphonates and denosumab when someone has hypercalcemia? Not the oral bisphosphonates. That's not going to work for hypercalcemia. So zolendronate versus denosumab. What's important to remember is both of them are associated with osteonecrosis of the jaw. It is not correct to say that denosumab does not cause ONJ. When they were compared head-to-head, interestingly, denosumab actually is either the same or actually slightly superior to zolendronate in terms of controlling hypercalcemia. The downside of denosumab is it can be associated with refractory hypocalcemia. So I've had people need to come in for IV calcium. It's considerably more expensive than zoledronate, but then the upside of denosumab is it can be used in severe renal impairment. I would say many hospitals will use zoledronate first, and if they don't respond, you can then rescue with denosumab afterwards. However, if there's renal impairment, you go straight to denosumab. So case number 5, which of the following pairs a proven cancer prevention action and the cancer it prevents? Is it A, tobacco cessation in bladder cancer, B, the hepatitis Z vaccine and hepatocellular carcinoma, C, decreasing soy consumption in breast cancer, or D, human papillomavirus and uterine cancer? And it looks like the most common one was tobacco cessation and bladder cancer with about 2/3, but a quarter of the people chose hepatitis C vaccine and hepatocellular carcinoma. The reason that's not correct is there is no hepatitis C vaccine. There is a hepatitis B vaccine, but there is no hepatitis C vaccine. If there were, it would be associated with a decreased risk of hepatocellular carcinoma because hepatitis B vaccines have been associated with a decreased risk. So tobacco, it's important to remember, is not just lung cancer. Head and neck, pancreatic, as you can see, multiple cancers that are strongly associated with tobacco. Ionizing radiation, this is not just from imaging studies, but this is when you're getting therapeutic doses of radiation. And then infectious causes, hepatitis B and C for hepatocellular carcinoma, Epstein-Barr virus for lymphoma nasopharyngeal cancers, and HPV, cervical and anal cancers, vaginal vulvar, penile, and oral pharyngeal. And this is the increased risk of obesity with multiple cancers. And so case number 6, a 38-year-old male presents with chest pain and shortness of breath. Chest x-ray shows a mediastinal mass suggestive of cancer. Which of the following blood tests would be most helpful to identify the primary site? Would it be A, PSA, B, CEA, C, CA19-9, or D, HCG? Oh, good. Everyone liked HCG, which is the correct answer. And so when you have this person with unknown primary, what do? You want to do a conventional chest abdominal CT scan, and it's preferred to a PET CT. You want to do focused tumor markers. You don't need to check every tumor marker under the sun. Many of them can be non-specifically elevated in someone with metastatic cancer. So a man with an adenocarcinoma in bone nets, you're going to check a PSA. A man with a mediastinal midline carcinoma, like this gentleman, HCG and AFP. And immunohistochemistry, also molecular profiling, can be very helpful at identifying the primary. And 50 to 60% are adenocarcinoma. Poorly differentiated cancers are about 30% of them, and 5% of them are squamous cell carcinomas, and other tumors are the other 5%. But what you really want to do is you want to find non-metastatic cancers. So a woman with axillary lymph nodes, she's got a node-positive breast cancer. Neck nodes with a squamous cell carcinoma, they have a locally advanced head and neck cancer. A young man, as I described, a germ cell tumor. And a woman with peritoneal disease, that's actually stage 3 ovarian, not stage 4, stage 3. So you want to try to find these. And then if you can't find these, you want to find treatable metastatic cancers. So cancers in which you can palliate and they can have a longer survival. And this is a list of the ones that you really want to be focused on finding. And so case number 7 is the last one. A 45-year-old premenopausal woman who has severe hot flashes during the day and night sweats. She has a history of a stage 1 ER-negative breast cancer diagnosed 2 years ago, treated with lumpectomy and radiation. She is not currently on hormonal therapy. Which of the following is the best choice for treating her hot flashes? And we have these 4 choices. And paroxetine, yes, is the correct answer for this one. So what's really important with hot flash studies is there has to be a placebo. For reasons I cannot understand, placebos work 25 to 30% of the time in improving hot flashes. It makes no sense, but it's consistently being seen. So the randomized controlled trials that have shown something that does better than placebo, I have them all listed here, and they decrease the frequency and intensity by about 30 to 50%. There is no effect in placebo-controlled trials of soy protein or black cohosh. Menopausal symptoms are really common among breast cancer survivors, partly due to treatment menopause and partly due to side effects. We really do not feel comfortable giving hormonal therapy for breast cancer survivors. And that's because the small randomized trials that did look at it did show an increased risk of recurrence. And this was regardless of whether it was ER positive or negative. However, we do feel comfortable with vaginal hormonal therapy since that really doesn't have much systemic absorption. And so the take-home messages are the treatment of SVC depends on histology, always have a high suspicion for core compression, immunotoxicity can impact many different organs, remember key cancer risk factors, and that there are a lot of different options for menopausal symptoms. And thank you.